You cannot trust a hemoglobin in an actively bleeding patient. Let me show you why. Think of this picture as your body's entire blood volume. Now, the liquid part of it is plasma, and that's made up of our GI system and our body absorbing the water that we drink, or in our patients that are in the hospital and they have an IV, those IV fluids that we're giving those patients. So that's the liquid part. And when we spin our blood down and take it to the lab, we divide it into three parts. Most of it is plasma. That's going to be like 55-60% of it. There's a little sliver of platelets there in the middle, and then the red part at the bottom, that's our red blood cells. And I want you to think of your red blood cells and your hemoglobin, which are those protein sites that oxygen is able to bind to. That is your hemoglobin, and that's going to be represented here by these little pasta. So for you to understand why the hemoglobin is not accurate in your actively bleeding patient, you have to understand how hemoglobin is actually measured. So look at this. I drew labs on our picture patient. When I send this tube down to the lab, what they're going to look at is how much of this blood volume is made up by these little noodles, or by the hemoglobin. How many grams of these do we have per deciliter of this? So the hemoglobin is relative to what's going on in the entire blood products. And anytime we lose blood, we lose whole blood. Take a look. Oh no, multi-systems trauma. And we gotta get some of the hemoglobin out too, and now my sleeve is wet, which is gonna bother me the rest of the day. So here we've lost a lot of our volume, and we lost a proportional amount of plasma and our hemoglobin. So if I drew this off of my patient who's missing half of their blood volume, lost in whole blood, the breakdown of the plasma and hemoglobin is going to be normal. But here's where hemoglobin actually changes. So when our body loses whole blood in any kind of trauma or vascular compromise, it takes us weeks to months to rebuild up that hemoglobin, or to reestablish those red blood cells, which have the hemoglobin, which carry the oxygen down to the cells. But it takes us hours to maybe a day or so, and our body says, best I can do is replace it with more plasma. And so now what I'm left with is a whole bunch of plasma and only a tiny bit of oxygen carrying capacity. So several hours later, after the acute blood loss, now our body has replaced it with plasma. And if we draw those labs again, we are left with now an accurate representation of a whole bunch of plasma and not very much hemoglobin. So how is a girl to tell if a patient has lost a significant amount of blood? If your patient's actively bleeding, we're not relying on a hemoglobin. Instead, you're going to use your eyes, your ears, your nursing intuition. Is that patient working harder to breathe because their lungs are confused as to why the rest of the body is hypoxic because it's missing hemoglobin? And so they're working harder. Their brain is going to be in panic mode, and these patients are going to say, am I going to die? They're going to have that impending doom. Their cap refill is going to be slow. They're going to be cool, pale, diaphoretic, and they're going to have a shock index. Do not wait for hypotension. That is the very last sign we're going to see in our patients in hypovolemic shock. And a reminder, what's a shock index? Our heart rate divided by our systolic blood pressure. And if you don't like math, don't worry. It just means if your systolic blood pressure is coming down and your pulse is going up, that means that your shock index is climbing and your patient requires a blood transfusion. What signs of blood loss are you looking for in your actively bleeding patient?